The second, if you compare in the older age group. So first comes in the older group is the facet, and usually the sacroiliac joint dysfunction is quite common. So disc, mainly the degenerative disc for the younger people, then facet, and then SI. These three are the most common pain generators for the lower back. So today, first we'll discuss about the sacroiliac joint dysfunction and the sacroiliac joint pain. Followed by, we'll demonstrate the caudal epidural and sacroiliac joint injection, and then we'll move to the lumbar facet joint pain. So if you have any questions at any point of time, you can stop me and we can discuss whatever your confusions are. So let's start with the sacroiliac joint dysfunction. As we all know, sacroiliac joint is one of the most common cause of lower back pain. Where it is situated? It is situated between the sacrum and the ilium. So it's a synovial joint, especially in the lower part. Upper part of the joint is fibrous. Now, being a diarthroidal joint with surface area is about 17.5 square centimeter, which articular surface spans from S1 to S4 level, and the sacral side is thicker, made up of hyaline cartilage, and iliac side is made of the fibroiliac cartilage. And in adult joint is irregular with coarse surface. Basically, it helps to absorb the fat. Now, as we discussed in the last class and with the ultrasound as well, so we have multiple sacroiliac ligaments, sacrotuberous ligaments, sacrospinous ligaments, which are making this joint stable. Mainly, two ligaments are important for the safe stability. One is the anterior sacroiliac ligament and the posterior sacroiliac ligament, which lies anterior and posterior. And another ligament in between the bones that is known as interosseous ligaments, which is also important for the stability of the joint. Regarding the function, it helps in shock absorption, force transduction from the lower extremities, and force transduction of the upper part. It is supplied by ventral rami as well as the dorsal rami. In the ventral rami, from L3 to S4, the nerves come to the sacral plexus and they supply to the anterior part of the joint, and posteriorly it is supplied by the lateral branches from S1 to S4. Sometimes the L5 dorsal branch also gives a tweak to the sacroiliac joint. So remember, whenever we are going for the denervation of the sacroiliac joint for the sacroiliac joint pain, we can only denervate the posterior part. Anterior part of the nerves we cannot denervate. That is why in sacroiliac joint it is usually said and clinically observed that the intra-articular steroid works better than the sacroiliac joint denervation. But the only problem with the intra-articular steroid is it's need to be repeated for the multiple times. So that's one of the biggest problem. That's why we move to the radiofrequency ablation for the facet joints. But remember, in radiofrequency, we cannot block the anterior branches. We can only block the posterior branches. Now, why an SI joint can become painful? An SI joint can become painful in infection due to metabolic causes, due to inflammatory causes, due to neoplastic causes, due to degenerative causes. That is the most common and we found in the most of the patients. And it could be possible it can be painful because of the traumatic causes. Now, among the intra-articular causes, they are the degenerative arthritis, they are the infection, spondyloarthropathy, which might cause the sacroiliac joint inflammation, which is quite common in case of ankylosing spondylitis. Then, in case of primary malignancy of the bone, or more commonly, the secondary metastasis into the sacroiliac joint can be an intra-articular cause of sacroiliac joint pain. Coming to the extra-articular causes, there could be possibility of the fracture, ligament injuries, and myofascial pain, which is the superficial muscles that can also cause. In the bacterial infection, commonly the staph, streptoenterococcus, pneumococcus, they can cause the pain. And among the non-bacterial causes, there are possibilities of the inflammatory arthropathies that can cause the pain, and they are mainly the acute cause of the low back pain. In the chronic cause, there might be again spondyloarthropathies, a tubercular infection, psoriasis, Rita's syndrome, inflammatory bowel disorder. Basically, all families of the spondyloarthropathy, they can cause chronic sacroiliac joint pain. Now, there is a common question that we got a lot of patients coming and saying, after my pregnancy, my low back pain started. Sometimes they relate it to the injection that has been given for the spinal anesthesia. What happens in pregnancy? Why pregnancy is an important factor to cause a low back pain because of the sacroiliac joint dysfunction. Now, in pregnancy, there are certain factors that are responsible for the sacroiliac joint pain. Among those, one of them is that during pregnancy, there are the relaxation of the ligaments. And this relaxation of the ligaments leads to increased stress and increased motion of the sacroiliac joint, which might cause abnormal tear within the ligaments of this joint. And there may be altered gait during the pregnancy because of the weight distribution, and which can cause more stress over the sacroiliac joint, so making the patient more prone to develop sacroiliac joint pain. It is one of the most common cause of sacroiliac joint pain in pregnancy. And this dysfunction might continue for longer duration. And this is the reason why post-pregnancy ladies sometimes feel low back pain and sometimes they relate it with the injection accidentally which are given. Now coming to the other risk factors include again a imbalance of the pressure which might occur because of the limb length discrepancy, means because of the any reason, accident, or maybe because of the congenital causes, one limb is shorter than the other one, then it might happen in the limb which is actually more active. Their stress over the sacroiliac joint is more and causing low back pain. Similarly, if the patient is having pain in one of the legs and which may restrict the movement of one legs, that can cause limb disturbance, not limb disturbance, but imbalance of the pressures, and that can cause the sacroiliac joint pain as well. Now, in the differential diagnosis, we can tell all the disorders like the spondyloarthropathy, its members, they can cause sacroiliac joint pain, which is secondary. There is possibility of the lumbar root compression, which is coming over the area of the S1, sometimes mistaken as the sacroiliac joint pain. It is possible that the L5S1 facet joint and the sacroiliac joint pain, as they are supplied by the same nerves, so in 5S1, L5S1 facet joint pain might be misdiagnosed as the sacroiliac joint pain. Then hip pain might be misdiagnosed as the sacroiliac joint pain. Then endometriosis, myofascial pain, piriformis syndrome that can be mistaken as the sacroiliac joint pain. So they are all comes in the differential diagnosis, and we need to differentiate them from other conditions. In the symptoms, usually there is the dull unilateral low back pain, sharper during the activities, and it might relate to the groin or thighs. Usually, it do not go beyond the knee joint. Pain typically in one side, definitely it's close to the posterior superior iliac spine. Pain of the sacroiliac joint pain may be referred to the butt, sometimes in the thigh, but rarely to the foot. Okay, there may be associated stiffness, morning increase in pain. Sometimes in chronic cases there might be paresthesia and numbness and weakness, but it is not commonly associated with the sacroiliac joint pain. Because of the sensitization, it might occur in a chronic stage, but in most of the cases, we do not find it. So, in the evaluation part, there are multiple manual provocation tests, among which the Favors test is one. You can search in the net and you can get how to do it. It's a very simple technique. Just ask the put the leg in figure of four position and press over the knee, so that if there is pain, stabilizing the opposite side pelvis, so if there is pain, pain will be exacerbated. So it can be evaluated in this manner. Now, in the treatment portion, in early cases, we can go for the conservative management with the NSAIDs. Sometimes, if required, we can use the opioids and paracetamol along with it. And definitely, correction of the risk factors, for example, may include an orthotics which can be given to avoid this limb disturbance, and along with the exercises and manipulation therapy may be helpful in sacroiliac joint pain. In the interventional management, there are the intra-articular corticosteroid injection and radiofrequency ablation, and nowadays we also give sometimes cryoablation for the sacroiliac joint pains. Remember, in sacroiliac joint, cool radio frequency and cryo is usually the preferred modality over the conventional radio frequency, because sacroiliac joint pain nerves cannot be located precisely like the lumbar facet or trigeminal rod. So here, if the modalities which causes a big lesion sometimes will be beneficial. Among those modalities, definitely two are. One is the cold radio frequency, and other one is the cryoablation. Now, in the treatment portion, we usually go for the diagnostic block. Diagnostic block is actually serves two purposes. If you are adding the corticosteroid, then it is diagnostic as well as therapeutic for the short-term benefit, but long-term benefit usually not obtained by the steroid injection, but sometimes it can cause the long-term effect as well. It gives us to confirm the location, whether it's coming from the sacroiliac joint or L5S1 facet joint or not. So we can make precise diagnosis with the help of them. Now, in contraindication of the sacroiliac joint pain are local infection, sepsis, coagulopathy, allergy to the drugs injected, and pregnancy if you are going for the fluoroscopy guided injection that we will be showing you today. Now, in the equipments, we need a fluoroscopy, needles, steroids, contrast medium, and as well as we require a local anesthetic. So these are the things that is required. Now, procedure we will be demonstrating. So we are not going into the detail of procedure of the sacroiliac joint block, but under guidance of the fluoroscopy, in short, we have to put the needle in the lower part of the sacroiliac joint. And after putting the needle, we should inject the dye. You see, in this picture, the dye is less, but here we have given the dye and you can check the dye, which is here. See, here this black is much less. But here when the dye is given, you can see dye is delineating anterior and posterior joint lines. And once we are confirmed that it is a sacroiliac joint pain, we can go for the injection of the corticosteroid, and usually 40 milligram of corticosteroid in 1 to 2 ml is usually sufficient for one facet joint. Now, for the radiofrequency ablation, a similar mechanism is done with the needles. Needles are placed by the sides of this foramen, or if you are using the cryoprobe, it can be used by the side of the joint. And by radiofrequency ablation, cryoablation, or cool radiofrequency, we can block the nerves that are coming from the dorsal foramina to the joint. As radiofrequency and cryo, you might not be doing at the beginning. I'm not going into the details. So ultimately, those patients which are not responding with the corticosteroids, you can go for these procedures. Okay? And the complication might be gluteal discomfort, hip pain, and could be posterior thigh pain. If you see the evidences, usually the intraarticular injection is having 1B plus evidence that is comparatively higher than the radiofrequency ablation. Parts radiofrequency ablation of the rami dorsalis, it's also mode of therapy, though the evidence is still lesser. Full radiofrequency is having the 2B plus evidence. Basically, the first choice should definitely be the corticosteroid injection inside the sacroiliac joint. And if the patient is not responding with it, multiple joint injections, then we can go for the either for the radiofrequency ablation or cool radiofrequency ablation, and nowadays for the carpi ablation. So it is in short the sacroiliac joint pain. If you want to know anything more about the sacroiliac joint pain, you can ask me. Otherwise, Dr. Roy will be demonstrating first definitely the sacroiliac joint pain, that is the sacroiliac joint injection, and the last days left over, that is the caudal epidural steroid injection. So anyone wants to know anything about it? No, okay, fine. Chinmada, you can start, I think.
Okay. So I am audible, no? Clearly? Yeah.
Yes, clearly audible.
Okay. So we have understood that whenever a patient of back pain comes, we should know that from where the pain is coming. Most of the time, if it is a midline pain, then maybe the disc is having the problem. If the pain is going towards the leg, then probably the disc is pressing a nerve, and that's why there is a radicular pain. In those cases, we will go for transforaminal epidural steroid. If that nerve root is not in the lumbar region and comes in the sacral region, then we will go for S1 nerve root block if S1 nerve root is affected. So that part we talked last day. But then if the degeneration goes on and there is problem everywhere, say in the facet joint is also affected, SI joint is also affected, even the discs are mildly herniated at all the levels, in most of the cases then patient will present with neurogenic claudication. So that is called lumbar canal stenosis. In those cases we prefer lumbar caudal epidural steroid injection, because that will spread in the whole epidural area, and the problem whichever is there in whichever area, it addresses a lot of areas, not a single or one particular area, because in lumbar canal stenosis problem is everywhere, multiple areas. Okay. Or if our say the pain is not in the midline, and not a lumbar canal stenosis, not a radicular pain, but it is a pyramidian type of pain. In those cases, we will suspect SI joint or facet joint. So SI joint, as Dr. Devjyoti has already told you, that how it presents. So we will do some clinical tests and all, and then if we think that okay, SI joint is the issue, then we will go for the procedure of SI joint. And if we find it is symptoms are matching with facet joint, then we will go for the procedure of facet joint. So first I will show you the caudal epidural. So you have understood where we will go at the caudal epidural. In those cases where it is a lumbar canal stenosis, neurogenic claudication, this type of presentation where the problem is at a I mean, it is a diffuse problem, not a single level problem. Okay. So I think you can see the mannequin and all. Okay. So first I am showing you how to give caudal epidural. So you have given a lot of caudal epidural, I think, in those who are in anesthesia, they have given a lot of caudal epidural in children. So that is in pediatrics, caudal epidural is much easier than the adult population, because in adult population what can happen, the loss of resistance through which we used to give caudal epidural in a child, in a baby, that loss of resistance you can in an adult patient you can feel at two places. One is just above the just okay. So one is just above the bone. You will see that you have not entered up to that depth. Just above the bone, when the muscle plane is not there. Between all the back muscles and bone, there is also a loss of resistance. And when you puncture that sacrococcygeal membrane and you are in the epidural space, then also you will have the loss of resistance, but it becomes very difficult without this x-ray or without any x-ray guidance, that where you are, you may be thinking that you are in the right place, but maybe you are placing your needle above the bone. So this is one thing. Second thing is, say it is a lumbar canal stenosis and patient have diffuse problems in whole of the spine, and patient symptoms are bilateral. So in that case, the needle should be coming like this straight. Okay, it should be in the midline. But if you do not see with the fluoroscope, then many a times the needle becomes like this or needle becomes like this. In those cases, the after giving the contrast, you will see the spread is unilateral and patient may have less effect. So let us see what is the how we do go for caudal epidural steroid injection. So first we will start with AP view. Here you can see this is the uh, hip part. This is the hip part and this is the head part. Okay, this is the head and this is the hip part. Patient is lying prone. Okay, patient is lying prone and I am standing patients in the patient's left side, because patient is lying prone and I am standing in the left side. So and C-arm is in the right side. So first I will go for, here it is not a lumbar spine procedure, so we don't need the Scotty dog view here. So first in AP view we will see the sacral area, mean the caudal canal area. So here we can, in AP view only, we can actually see that where is the caudal canal. Okay, so this is the caudal canal, this is the caudal canal. Okay, so you can see that this is the midline. These are the sacral spines. These are the sacral spines we can see. So we know that caudal canal starts from S3 lamina. Lower half of the lamina usually it is separated, and S4 and S5 is always it is separated. So here in AP view, our aim is to fix that from where we will start and the direction, these two things. So we know here is the tip, so we will go at least 2 centimeter below. From here we will start, or we can go a bit more below also, 2 to 3 centimeter below. And our direction of the needle after going to a certain depth, it should be in the midline. So from this view we want only this much to achieve. So let's see. So first we will see where is the tip. Okay, sure. So more or less this is the tip, and this is the tip, and I want to go at least 2 centimeter, 2 to 3 centimeter below I want to go. So from here I will go, I will puncture the skin, and I will maintain a direction completely in the midline. Should okay. So I can remove this and should. So my needle should be going completely in the midline. Let's see if it is going in the midline or not. Okay, so it is going in the midline, but I don't know that what is the depth, whether I am on the bone or inside the bone I have entered or not. So after going to some distance only, I will go in the lateral view. So in lateral view, what I want to understand the depth to enter in the epidural space. So you know that lumbar, our spinal cord, main cord ends at L1, dural sac ends at S2, and so below S2 everything is epidural space, continuous with the epidural space, and so a needle which is coming from below to up, I mean it should not go above lower level of S2, otherwise it can puncture the dura also. So we can see that I am going above the posterior plate of the sacrum. So where is what are the posterior, where is the posterior plate? So here you can see that if this one is S1, this one is S2, S3, and here will be S4 and 5. So here you can see vertebra, these are the vertebral main body of sacrum. Okay, main body of sacrum, and this part as the posterior laminas, posterior fused laminas are these one. So where is the epidural space? So epidural space is here, in this area is the epidural space. This plane, you can see this plane is the epidural space. So my needle should have come like this. Okay, like this. So here I have to enter in this area. So I will remove the needle and I will go much deeper. Let's see. So now the angle is okay, but should, so now it is going in the right place. Okay, but I need to check again in AP that whether my direction is correct or not. In lateral, I know that I cannot go more than this because this is S2, lower end of S2. I should not cross that part because dural sac will end in this area. Okay. So again in AP view, I will check. Okay, so you see that from above, it you cannot understand whether you are going in one side or you are not going in the opposite side. So I am going to the left side. One thing I did not do today, which I should have done, that is the side determination. Shoot once. Okay, so left side of the screen and left side of the patient is perfectly all right. So this you need to do before every procedure. Okay, now I will remove the needle and give another direction. So it is gradually going in the midline, but still, okay, now it is going in the midline. So I can go a bit more. Should. Okay, now I will check in lateral again, that whether I have reached up to lower level of S2, but then that is not needed every time, because that is the highest limit. You can inject at S3 also, that is the highest limit. Okay, so you can see I am perfectly in the epidural space, and this is the S2. So I'm just touching the S2, but you don't have to come this much. This much is also all right. And this is the complete epidural space. So in lateral view, main thing is to see the a clear lateral view. That is the main important thing. You should see a clear body and then the fused laminas. Then only you will be able to see the epidural space. If it is not a clear lateral view, then what will happen? Then here this one line will become two line. Here it will become hazy and two lines. Okay. Here even these border will become hazy. So let me show you how it looks if it is not a true lateral. একটু ওঠা তো a bit more. Okay. So if it is not a true lateral, see what happens. So you see, this is a dirty picture. Neither you can understand that which one is the epidural space. And here also, this picture is not very clear. So again, make it true lateral, and you will see. So here, the area which is lucent area, that will become more clearer if it is a true lateral view. Okay, so it is a more clearer view, more lucent area. So that is what. So always while seeing the lateral view, you need to see that whether you are seeing a true lateral view or not. Okay, so this is about the caudal epidural steroid injection. And as I said, many a times needle comes and here only it bends, and you will feel a loss of resistance also here many times. But when you check with the x-ray, you will see you are not in the space, you are just above the sacral posterior part of the sacrum. Okay, next, so is there any question in this part? Otherwise I will go with the SI joint injection. Okay, so I think you don't have any question on this part. So we'll go with the SI joint injection and একটু right এদিকে. Okay, so before you go for SI joint injection, we must understand few things. Okay, এটা একটু দে তো মানে, so you see a few things, like this is the SI joint. Okay, this is the SI joint. This is not a hinge joint or not a ball and socket joint. These are called diarthrodial joint. And what is the meaning of this? Here, this bone is a bit at the deeper level, and this bone is covering it like this. Okay, so you can understand that if middle bone, the sacrum is like this, so ilium pelvis bone, ilium bone, hip bone is coming and covering like this. So you can understand clearly that, say, this is the right side and this is the left side. So here in this bone, if there is a joint between these two bones and this is covering from above and patient is lying prone, so your entry is from this side only, from outside. So how will you enter? You cannot enter straight because this is covering. You have to go from see the joint from this side. So you have to join. If you see from this opposite side, then only you can see the joint. Okay, so this leads to contralateral oblique view for this SI joint injection. Okay, so remember, whenever we have done any injection in the lumbar spine, we used Scotty dog view and ipsilateral oblique view. This is the area where we are using contralateral oblique view, because you can there is nothing to memorize. Just understand, this is sacrum, it is covered by ilium. From posterior side, if you want to enter, you cannot enter straight. You have to go this side. So because opening is at obliquely, so obliquely you have to go. So this gives us a contralateral oblique. For right side, you have to see from the left side. For left side, you have to see from the right side. Okay, this is one thing. Second thing, though you can see that it is a big joint, but it is not a big joint. You can see this part of the hip bone. This is a big hip bone and this is sacrum, but you can see that this part of hip bone is actually hanging and not forming any joint here. Okay, there are many ligaments which are called sacroiliac ligaments, but this part is hanging. This is not joint. Joint is very small here. Only small part is a joint. Okay, not the whole part. The small part is a joint. This is one another point to understand. Okay, that every part is not a joint. Thirdly, this joint, when we will see in a three-dimensional picture, when we will see in a AP view, it will give a two-dimensional picture. Then we will see two different type of lines, two different joint lines. What is that? One is posterior joint line here, this one, and one will be anterior joint line, this one. Okay, so here you can see clear joint this area. Yeah, this is the clear joint line. So this anterior joint line you can see, and you can see the posterior joint line, but this joint line is small. I mean, these areas are not joint. So when we will go from the posterior joint, posterior approach, when we want to enter the joint, we will approach the lower one third of the joint. For one is that we want to enter inside the joint and not in the just under the tendon. And secondly, it has been seen that upper part of the joint is fibrous in adult patients. Most of the adult patient is fibrous, and lower part is the synovial sac you can find. So we will target the lower part of the joint. This is another thing. So first thing, to perceive the SI joint, which one is the SI joint? And second point will be, which one is the anterior joint line and which one is the posterior joint line. Remember, we will try to see, say this is sacrum and this is like joint. We will try to see from one side and we will try to make it in a single line. Of course, it is not like a smooth like a wall, that whole joint you will see like this. No, this is not like that. So this is I mean, like there are ups and downs in the joint line walls. So every full joint you cannot see, even with oblique view you cannot make the complete joint line as a end on view. That is not possible. So some part of the joint line will be overlapped. We will target the lower part of the joint line, so that anterior part and anterior joint line and posterior joint line, only in the lower part it gets overlapped, and we can see from one side like a end on view. Okay, so let us see the SI joint first. Okay, so this is the SI joint. This is the AP view and this is the SI joint. So here also I will first check that left side is left, patient's left and my screen's left is okay or not. So screen's left and patient left is normal. I mean, it is there, same. So it's okay. So now I shoot again. Okay, let us see where is the SI joint now. Now you see this is the hip. Oh, just a minute. You see, this is the hip bone. Okay, this is the hip bone. So this part you can understand, this most medial part, this is a hanging part on the bone. Okay, this is not touching the sacrum, as I have already showed you. Now let us see the sacrum. Where is the sacrum? So this is the sacrum. Sorry, actually this is the sacrum. Okay, so this is the sacrum. Okay, now you can see that completely this part is overlapped. This part is overlapped. That means this part is, you can say that ilium is overlapping the sacrum. But now you see that in this overlapped part, do you feel the whole part is a joint? Whole part is a joint in this overlapped part? No. The whole, this part is actually hanging part. This is not joint. This is not joint. Then where is the joint? Only this part. Only this part is the joint. Okay. Now question comes that which one is the joint line? So we can see this is one joint line and this is another joint line. Okay, this is one joint line and this is another joint line. Okay, so we can see two joint lines here. Of course, no, this one is actually, this one is joint line and this one is joint line, and here it is clear. Okay, this one is joint line and this one is joint line. So only this part, this small part is the joint, other part is not joint. Now we have to decide. So we have understood that which part is joint and which part is hanging bone. So now we have to decide that which one is anterior joint line and which part is posterior joint line. So think yourself that if this one is covering, this bone, this outer bone is covering, and sacrum is anterior, and ilium is posterior, and this is a diarthrodial joint. So which joint line should be medial and which joint line should be lateral. So medial joint line is the posterior joint line and lateral joint line is the anterior joint line. So medial joint line is the posterior joint line and lateral joint line is the anterior joint line. Okay. So now we will try to overlap only 1/3 of the total joint line. We will try to overlap only 1/3, only this much of the total joint line. Okay. So let us see. So let us target the right side so that we can do the left-sided contralateral oblique and we see the joint line overlapped. Okay. Left side contralateral oblique. Step by step. Yeah. এই একটু হাইটটা বাড়া হুম হুম Okay. So by contralateral oblique, you can see both the joint line are coming together. This distance is getting down. Okay. So we will make a bit more oblique and we will see only the lower part will get overlapped. Do more. Hmm. Okay. So it is gradually coming to and you cannot expect that complete overlapping will be there. If some part is overlapped, you should be happy. So this part is overlapped and you should be happy. Okay. So we can try to see that if a bit more overlapping can be done, but I think this is acceptable. But let's see. Okay. So this is okay. Anyway, so তোমার থেকে নিয়ে না আমি এদিকে we will keep the target area in the middle part of the screen. Okay, sure. No, this is to conquer oblique. Reduce the oblique angle a bit because the joint has become smaller. Okay, sure. So this is okay. Here one important thing is should that this joint is a bit less opened as we have made this joint line is a bit less opened as this has been made by us and not the should and not a actual human being's joint. So otherwise a normal SI joint opens a bit more. Okay. So again this will again be a should tunnel view approach. Tunnel view approach means we try to see the needle in a end-on view. It should look like a dot. Though every time a tunnel view may not be achieved, but that is okay. Should they should okay. So I'm going inside the joint. I'm going inside the joint. So I'm inside the joint actually. Should So this is a tunnel view. I am inside the joint. Now, how to understand that I am inside the joint or not? First, one point is just go for the contrast. You can inject the contrast and it will have a characteristic spread. Another point is we can make now AP view and you can see my needle is placed inside a joint line, that is medial joint line, posterior joint line. Okay, so maybe more AP. Oh, this, what a minute. Shoot. Okay, I was in the line, but I have not reached at that point. So now I have reached actually. So this is the joint. Okay, sure. Okay, show me in earlier view that you will be. So you can see it is in the medial joint line, and let us see now in, yeah, that's okay. একটু কম করো। হুম, reduce এদিকে করো। হুম। So this is okay. Actually, now I have gone a bit more. Earlier I was going a bit less. So this one is the joint. Shoot. Yeah. So this is in the joint only. So this is going through the joint. This is going through the joint, and so this is going through the joint. Sure. Yeah. So just take in your side. Hmm. A bit less. Decrease the angle. Hmm. Yeah, so this is in the joint only. So I can palpate actually. I can I can feel actually that I'm inside the joint. So this will be looking like this only. Okay. So we can go in the opposite SI joint also. Again, show me the AP. Hmm. Hmm. Okay. Okay. Now we'll target this SI joint. Okay. This SI joint. So we'll see the contralateral oblique in the right side. We are targeting patient's left SI joint, and I am doing a contralateral oblique, right contralateral oblique. Now I want this. Okay, so this you can see. Hmm. Oh, this. Uh, shoot. Okay, so you can see only a small part is overlapped. This part is overlapped, and when one part is overlapped, you can see the lucent area. So let me check again. Shoot. Hmm. 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 Should. Okay, so can go in actually. Should. Here it is difficult to palpate anything. I mean, feel anything because it is made by human. But otherwise, so this is in the SI joint. This is the correct picture. Let me make it AP view. Just AP view, and you will see. Should. So you will see. So you see this is in the medial joint line, and earlier it was in the overlapped joint line. So this is correct. You can understand that we are in the SI joint only. Okay. So these two methods you can feel, you can do this one also, or you can give contrast also. And of course, if now I have stopped the needle at the medial joint line, remember if I go more deep, then of course this needle will come up to this much, because it is ultimately joint space. So it will start from one joint line and then it will traverse to the other joint line. Okay. So I think this much is clear. Nobody has any question. If anybody has any question, please ask. Otherwise, we will go with the facet joint part. Devjyoti will talk about facet joint, then we will show. Any question? Because these are very basic starting procedures. Okay. Devjyoti?
But it's surprising no one is having any questions. So it's a query whether they're listening or not. They are present. Prince
Yes,
is there. Yes, she
listening.
is there. Okay, fine. So let's start.
Dr. Samprita, are you there?
We are here.
Okay,
Okay,
okay.
fine. So let's start.
Yes, please.
Now, in older age, as I told, facet, anything you want to tell or ask? No, fine. So, another most common cause of low back pain, especially on the older age group, is definitely the facet joint pain. And facet joint pain may be associated with the disorders like spondyloarthropathy, but it can happen because of the degeneration, old age, along with the disc problems. And there are various other conditions that can increase loading over the facet joint, and facet joint can be painful. And it's an important cause of pain, and it was first invented by Wormley in 1933. Initially, it was not that popular, but mostly at that time, the diagnosis of the low back pain was concerned on the disc. But it has been demonstrated a potential source of pain, and it has been found that facet joint intervention nowadays is the second most common intervention after the epidural steroid injection. So, what is facet joint? We know pair of facet joints are there in the posterior lateral part of the vertebra, and one inferior articular process, the upper vertebra joins with the superior articular facet of the lower vertebra, and they form this trijunction to carry the weight of the body. So what are those? Disc and intervertebral disc and the vertebral body. They carries around 80% of the body weight, whereas these facet joints in both the sides carry 10% of the body weight each, and that is making complete three joint complex or a tripodal structure. These are the two synovial joints which is covered by the hyaline cartilage, and there is a capsule which lands just by the side of it, and making it a true joint with synovium and stability. It provides and can be stressed when the body is twisted, okay, or the body is bent to the sides, then there is more load over this joint. It has been found that the volume of the facet joint at the lumbar area is usually 1 to 1.5 mm, whereas at the cervical area, it is even smaller. It is around zero point 0.5 to 1 ml. Now, with the lumbar region, especially to the anterolateral part, joint capsule is replaced by the ligamentum flava. It is actually replaced, covering the anterior part of the joint. So the significance is if in case we accidentally put too much fluid inside the facet joint and it accidentally crosses the ligamentum flava, can cause epidural anesthesia. So we have to be careful regarding the volume that we are injecting in a facet joint. And posteriorly to this joint lies the multifidus muscle. And remember, the nerve supply of the facet joint and the multifidus muscle are the same. So multifidus muscle contraction works as an indication while we are going for the denervation facet joint. Now, if we say about the nerve supply, facet is supplied by the articular branches that arise from the medial branches of the dorsal rami of the spinal cord. That means we all know this spinal nerve, which comes out from the foramen, divides into two parts. One is the anterior part or ventral part, which is the main motor and sensory supply of the body. And the other one is the dorsal part, which is the supplying the back muscles or core muscles of the back. Now, this posterior branch again divides into three branches: lateral, intermediate, and medial. Lateral most branch, just we are talking about the SIJ, they are supplied by the lateral branches of the S2, 3, 4, and L5. So, this supplies the sacroiliac joint, this supplies the thoracolumbar fascia, that is in the lower part of the vertebra, and lower part of the spine area. This basically thoracolumbar fascia is a big area. We have discussed previously with the product of the ultrasound also. We have shown that also. So, the paraspinal muscles, that is another area that is supplied by lateral branch. Intermediate branch supplies only one muscle, that is the longissimus, and the medial branch is the largest branch. So it supplies three important structures. So one, the facet joints, then the multifidus muscles, intraspinous ligament, and the periosteum. So these are the supply of the facet joint. And remember, one nerve is dividing into two, one medial branch is dividing into two, and it is supplying upper facet joint and lower facet joint. So actually, one facet joint is supplied by two branches of the nerve, one coming from above and one coming from below. So say this is L4 and this is L5. For example, don't consider the lower one. Say this is L4 and L5. Then below the L4 comes the, say this is L4. So below the, this is L3 then. So let's say L3 and L4. Then it is L3, then it is the L3 facet joint, and this is the so sorry, what I was a little confused. Again, go back to this area. So say this is L4 and this is the L5. I replied that only. So what happens? This is supplied, this joint is supplied by one branch from the above and one branch from the below. But what happens in actual, but as the nerve is coming below the vertebral level, so say L4 5 facet joint, they will be supplied by a branch of the L4 and the L3. So if the facet joint is L4 5, it will be supplied by the L3 and L4 branches. It is L3 4, that it will be supplied by the L2 and L3 facet joints. So L3 median branches. This happens because of the nerve coming below the vertebra, but it doesn't happen in case of cervical spine, because in the cervical spine, the named nerve comes from above the vertebra. So in cervical area, if it is the C4-5, C5 facet joint, it will be supplied by the branches of the C3 and C4. So it is only the difference of the names, but in short, you can think if it is a joint, it will be supplied by the nerve which is coming from above one level and below one level. That is very easy. So if we take this joint, say this is L5 and this is L4. So this is supplied by the L4 and this is supplied by the L3. So one coming from above and one coming from below. And it has been found this medial branch is located at the junction of the superior articular process and the transverse process. So it lies in a groove at this point. Okay. So they are going like that and then supplying the joint. So to diagnose a facet joint A, we can do two things. Either we can inject inside the joint, that is the intra-articular injection, or we can inject over the nerve supply of the joint, and that is known as the medial branch group. Now, to find out the medial branches, medial branch lies in a groove which is formed by the superior articular process and the transverse process. And when we learned about the Scotty dog, it lies almost at the eye of the Scotty dog. This is the junction superior articular process, and this is the transverse process, and it lies at the eye of the Scotty dog. So coming to the clinical presentation for the facet joint pain. So facet joint pain, as it is an articular pain, it usually worsen in the morning, and the patient is having inactivity for prolonged period of time. Pain usually increases. Facet joint may be increase painful because of two reasons. Either it may be degenerative cause or it may be an inflammatory cause. These are the most common causes. Definitely traumatic and other causes, infective causes are always there, but they are less common. So if pain is increases in the morning and inactivity, then if the pain, this relief period, that means In the morning, it lasts more than half an hour. It is most probably an inflammatory cause. And if it is less than half an hour, it is relief, then it is probably it's a degenerative cause. Pain onset is sudden, which may increase following twisting, bending, or sudden rotational movements. There is tenderness, which is present over the paraspinal area, not at the center, just over the inflamed facet joint. And in these patients, if we examine, the back pain will be more than the pec pain, bed pain, leg pain, and the location will be by the side of the midline. Pain will increase on extension, rotation, and lateral bending. And pain is related to the movement. At rest, there will not be any pain. And usually the patients say, when I am sitting, there is usually no pain. When I'm standing, suddenly sitting to standing increases the pain, because in sitting to standing posture, usually the spine becomes more straightened, more load shift towards the facet joint. And when the patient starts walking, initial period of time, the patient is pain free. But on prolonged working, pain at the back again recurs. And this pain do not follow the dermatomal distribution pattern, as they are not irritation at the root. It is because of the facet joint pain, but it has a pain referral pattern. Means though it is does not goes in the dermatomal pattern as the radicular pain, it has a pain referral pattern. So what has been found? It has been found that pain from the upper facet joint, they go to the flank, hip, and the upper and lateral thigh. And from the lower lumbar facets, they more go into the thigh, lateral, and the posterior aspect. Pain of the L4-5 and the L5S1 facet may cause pain in the lateral calf. So these are the pain referral pattern in the facet joint pain. Now coming to the radicular symptoms. Can facet joint cause a radicular symptom? This is one of the questions commonly asked by the students. So the answer is yes, it can cause a radicular symptom, but in certain conditions, like a facetal cyst compressing on the nerve root, like a facet joint hypertrophy, which is compressing on the nerve root, and in case of osteophytes, there could be a possibility of the facet joint pain. So it is a facetal cyst, and it is compressing. If it is compressing over the nerve root, it can cause a dermatomal distribution pain of the facet joint pain. You can see here is the facetal cyst. Now coming to the imaging, which imaging is the best for the facet joint? It is a CT or MRI or bone scan. It has been found that CT and MRI is very poor correlation, both of which having correlation around 40% of the cases. Whereas the chances of diagnosis of the active lesion or active in uptake of the radionuclide is more in case of bone scan than actually correlate more with the facet joint pain. But bone scan is not commonly done, and except in cases of the spondyloarthropathy or the inflammatory disorders, or if you are in a diagnostic dilemma, you can go for the bone scan. Otherwise, you can actually go for the radiography, and then you can go for the diagnostic facet joint injection. Though there are radiological gradings available for the facet joint pain, but it is rarely used because it is not having direct relationship with the facet joint pain. Now, there is a question that in diagnostic block, we can put local anesthetic in the facet joint and find out whether there is a pain relief or not. Or we can do another technique. We can block the medial branches supplying that facet joint, and that is known as the medial branch block, and it is also a diagnostic block. Which is better, blocking the joint itself or blocking above and below? Answer is there are certain advantages and disadvantages of both type of blocks. And you have to consider patient to patient. So what is the advantage of the median branch block? The advantage, definitely it's easy to perform. Prognostic value for subsequent radiofrequency denervation is higher. But the disadvantage is that intermediate and lateral branch may be blocked if your volume of injection is more, and it can fail to locate the pain generator because the drugs spill over to the other areas, and that is actually making loss of our diagnostic potency. But prognostic value is definitely more in case of medial branch block. Coming to the intraarticular injection, advantage is definitely it is more accurate. You don't require two pricks for a one joint. A single prick is good enough. But disadvantage is it is technically difficult to perform. There are chances of rupture, especially if it ruptures into the anterior part. enter the medial part especially, and the drug spill over to the epidural space, then also the diagnostic efficacy is lost, and there are chances of the epidural and subarachnoid strain. So you have to consider patient to patient. Now coming to the false positive rate for the lumbar facet joint block. It has been found around 27% of patients there could be false positive. That means the you have done the diagnostic intervention and then you have found that there is pain relief, but when you have done the radiofrequency ablation, there is no pain relief because your diagnostic was the false positive. So how to reduce this false positive rate? First of all, perform a placebo controlled block. But though sometimes it is not possible because I am just giving saline and asking and taking money for it, it doesn't be a good choice. So we can go for a comparative block. That means once we'll do the block with the lignocaine and then we'll do the block with the ropivacaine or bupivacaine in two different setups and we'll check the pain relief period. In one case, it should be shorter and the other case, it should be higher. So that could be one possible way. Then aim at the lower part of the facet joint. So if you are in the upper part, there are chances of your needle moving up and going towards the foramen, giving a false positive rate. Reduce the volume of injected. Do not go more than 0.5 ml of the drug because in those cases, chances of rupture, chances of the spillage to the nerve roots, they are more. Be judicious to use the superficial anesthesia. You have given so much anesthesia that instead of skin, it has gone to the joint and deeper part of the structure. So be careful on that part. Consider a single needle approach that also reduces the intra-articular approach that also reduces the chance of false positive rays. Then consider using the computerized tomography. Basically, good guidance can help you get a better result and avoid the use of the sedation of the intravenous opioids that will falsely reduce the pain. So these are the ways by which you can actually go for the reduce the false positive rate. Now coming to the facet joint block indications. So to exclude or include the contribution of facet as a cause of low back pain. This is our main goal. And usually the specificity is around 80%. First, definitely go for the clinical assessment. And if you are clinically satisfied that it could be a facet joint pain or this back pain, we need to go for a diagnostic block, then only you should go for this facet joint pain. My procedure will be demonstrating, not going here too much. So it is basically putting the needle either inside the joint or inside the medial branches. And then you have to inject the drugs. And usually for our setup, we prefer 1% lignocaine, 0.5 cc inside the facet joint, or sometimes it is mixed with the dipomedrol, 5 milligram approximately inside the facet joint to give a therapeutic benefit along with the diagnostic block. So these are the techniques, not going into the detail of the techniques because the details will be discussed by the Dr. Roy. Coming to the complications, usually complication rate is low, but there could be local infection, hematoma, transient back pain. So these sort of complications are possible. But if you are doing it carefully, the chances of complications are really less. So that's all about the facet joint pain. So any questions regarding the facet joint, you can ask me. Otherwise, Dr. Roy will be going for the demonstration. So no questions. So let's go for the demo.
Okay, so we'll go for the facet joint injection. যেকোনো একটা ঠিক আছে So facet joint injection, you have already seen that spotlight for everyone. So we can see all these facets. So here only one important thing is these are facet joints. Okay, these are facet joints. So here just remember the lower facets, lower vertebra or lower articular processes, lower articular process, they always hold the upper articular process from outside like this. Okay, lower articular process is holding from lateral side and from below. So that is the you can see, and this is a true, this we are seeing a AP view from posterior side. If we just do like this, you can perceive the Scotty dog at every level. Okay, so this you can do this side also, and you can see the Scotty dog at every level. So if it is the Scotty dog, then what can we see? This is the front leg, this is the face, this is the nose, and this is the eye of the dog, this eye of the dog, this is ear, this is neck and body, this is the body of the dog. That means we want, if I target the eye of the dog for medial branches, that means I am targeting this eye of the dog, means medial branches are coming like this, in this area, in this area, in this area, in this area. These are the areas for uh, medial branches, to target the medial branches. So this is the superior articular process and transverse process. So here at this junction we will go for median branches. And when we talk about the facet joint intra-articular, which is not very popular nowadays, we also don't do, mainly we do at the median branches. But of course, if there is some acute inflammation, say for some reason acute inflammation is there in one facet joint and you want to give intra-articular, then that means the ear and front leg, between ear and front leg of the upper Scotty dog and lower Scotty dog, the ear. So between that is the your ear facet joint. Okay, we can target that one. So let us see. So same thing like earlier. First step, to see the levels. Okay, and second step is to see that whether right side is at the right side or left side, and left side is at the left side or not. Okay, so this is a AP view, this is the AP view, and we can understand, annotate. So how we do the leveling? So this part is iliac crest. So if in this level iliac crest is there, so between two iliac crest, it is going between L4 and L5. So this much is fixed. So we know that this is L4. Okay. So if now I want to do a Scotty dog view, so if I want to go for a this left side, this is left side, this is right side. So patients say L45 facet I want to target. Then I have to search facet here and or here, left side L45 facet here, and right side L45 facet here. And likewise, the upper one will be L34, L45, L23. So in this way. So before that, we need to go for a Scotty dog view. So we remember, first point was understanding the level. Second step was to see right side or not, left side or not. Third step was getting true AP view. True AP view has two steps. One step is pedicle to spinous process distance should be same. Okay. Second process is making the end plate parallel. Here there are two end plates are there. So in that case, say as I told you, the nearer end plate should be parallel, which is your target point. Okay, so say I want to go to this facet. Okay, so this is L4 and this is L3. So left side L34 facet, if I want to go, then where a facet will be here, because facet joint means inside the facet joint. If I want to go, then I will go between the leg and ear of the lower Scotty dog. So this one will be the facet. But then which part I will make one line of the end plate. So either this one or this one, anyone will do actually. So here one end plate is almost single line only. So parallel, making the end plate parallel is also done, you can say. So if I am going for left L3 for facet joint intervention. So now two important one or two important thing is okay. So true AP view has been done. Now last step, fifth step is to get a Scotty dog view. So we will for left L34 we will go, we'll make a ipsilateral oblique. So do it. So we will see that, we will see the left Scotty dogs clearly. Left Scotty dog. So patient's left side, left Scotty dog. A bit more. We can go a bit more. Okay, it's okay. So we can see the Scotty dog. ওদিকে টান একটু। Okay, okay. So L34 left side. So you can see that this is 4 and this is 3. L34 left side. So this is our target. Here we can see one Scotty dog in this way. And nose cannot be seen. Okay. So this is one Scotty dog and another Scotty dog is at so like this. Okay. So our target is to go in these joint, if I want to go intra-articular, and if I do not want to go intra-articular and I want to ablate this joint by median branch block, then I will target the median branch here and here. For every joint it is 2 median branches. Okay. Say I want to include the lower facet joint also, L451 also, then I will include another one here. So this one will be supplied by this one and this one, and upper one, this one is supplied by again this one and this one. Okay. So it is like that. So now my first, say I want to go for L34 left side, so I will put my needle here, one. দেখি পড়িয়ে ফেলি। হুম 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 Okay, so just at the tip, if I want to go in the L34, hmm, hmm, uh-huh. So I'm just going a bit laterally. I will go a bit medially and show. So I've gone too much medial. I will go a bit lateral now. Shoot. Let's shoot. There. Okay, I'm going there and getting okay. I'm inside the joint. Shoot. So just make it AP. So AP will look like this, and we will see in the lateral view that at which depth we are there. So in lateral view, I will be there in the posterior elements part, because I will not go that much anterior that it will touch the spinal canal. So I will be in the posterior side of the spinal canal. So you can see, so these are facet joints only, these are facet joints, these are facet joints. So you will be in this bony area, okay. So it is okay. So you are inside the joint only, it will be looking like this only. So you are inside this bony area. Your needle should not go through and through the joint and come up to this much. It should not should not happen. So this is okay. Facet joint intra-articular. Let us go to the previous picture, and now I show you the median branches, both median branches for that facet joint, that specific facet joint. Again, the same scotitop view. Let us take the same scotitop view. Okay, so same scotitop view. So say left L34 only, I want to do a diagnostic median branch block. So here and here. So in these two areas, there are two median branches, and I will just directly sit on the eye of the dog. Okay, shoot. Shoot. Okay, so here I will go eye of the dog at L3 level. So I'm going up, I have to go down. Shoot. Oh, too much down. Okay, so it is more or less perfect. Shoot. Okay, this is the one eye of the dog at the L3 level, and another eye of the dog I will go at L4 level. Ah. Hmm. 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 Sure. So this is another okay. I'll make it more I. Okay, so this is okay. Remember, so we are giving local anesthetic, so it doesn't matter if you are a bit down. So this is the eye of the dog. This area is the eye of the dog. This area is the eye of the dog. So this is okay. If you give local anesthetic, it will spread here. Local anesthetic steroid will spread here. And most of the time, we are giving only local anesthetic for diagnostic purpose. And then we have to go for radio frequency ablation of these median nerves. Okay. So this much only. You can go for immediately for a short-term pain relief. Steroid also you can mix with the local anesthetic, and you will get a good. You can diagnose that whether the pain patient is getting pain from facet joint or not. But a contrast দেখিয়ে দিতে দাও তো।
Okay. Dr. I is showing some contrast distributions, but as the last class was quite late, so I have given the study material and the questions today. So you just complete the MCQ within this week. I'll be sharing the study material for today as well, okay, as well as the questions. Okay, if you have any question, you can get back to us, even with our WhatsApp as well.
Can I ask a question, please?
Yeah.
Would you recommend doing like a medial branch block for bilateral, or you would rather go only for unilateral first?
Patient symptom. It is the if patient has a unilateral symptom, you will go in one side. If your patient has bilateral symptom, you will go for both sides. And even at multiple levels, it can be say 3 injections in right side, 3 injections in left side. So that is also possible. Yeah.
Because you know the medial branch, it supplies the multifidus muscle. So if you go then for bilateral RF, that might cause weakness and that might increase the back pain, right?
This is nowadays, yeah, it has come that it can cause multifidus weakness, but I mean directly.
Not the only muscle, there are multiple muscles there.
Hmm. Yeah, but then this procedure is going on for a long time, and we have also done multiple procedures. So these things are coming gradually. That okay, people are doing multimeter stimulation also by spinal cord stimulator and all, but then whether really it can cause a significant multifidus weakness and then patient can get pain or not, I don't know that much. But then if you have a if you get diagnostic block positive, you can go for RF, and patient will get relief. And otherwise also RF, say it affects lasts for 2 years, and it is the sensory effect which lasts for 2 years. I think within few I mean say within 1 year only again the nerve starts growing, and then muscle will again start its function anyway. So multifidus wasting and weakness, how much it is practical, I don't know, because we have done a lot of RF of facet joints, and they are good, and they come back also.
Okay, thank you.
Hmm. So I show you some contrast spread, okay? Because this part we do not show in the mannequin, just showing you. Yeah, one minute. Okay, just see. So this is SI joint. So after putting the needle in the tunnel view approach, so we are giving the contrast. Contrast should spread up. It should not be staying in one side. And sometimes contrast you can see here, it is depositing in the lower part, because this is the capsule, joint capsule, so it can deposit in the lower part, but it should be going up. Most of the time it should go like this, it should go like this, okay, then you are inside the joint. And so let us, so this is before, so you can see nicely contrast is going inside the joint, going up. So this is another contrast spread. So here also contrast is going up, and some contrast, this is showing the capsular deposition. This is the lower part of the joint capsule. Okay, anyway, so Hmm. So this is another tunnel view approach. Tunnel view approach. After giving, you can see the contrast has gone up. This was a clear picture, and after giving, this contrast is going up. This is also contrast is going up, and this is a very nice picture showing the complete joint. So you can see. So, but then this is very rare. This type of completely delineating the joint every time you do not see, but you can see here that how much is the joint. This iliac bone, hip bone covers a lot of sacrum, but joint is only this much. This is the shape of the joint. This is pear shaped. So this joint, and this is also from lateral view. You can see the delineation of the joint. So this one S1 foramen. A minute. I show you some more pictures. So this is the, as I showed you that we can go for the medial branches. So, so this is the positioning for medial branch. So this is L5 median branches. This is for L5 S1 facet. Okay. So these part, remember these joint is L5 S1 facet. So this is L5 and this is S1 area, means sacrum area. So this is L5 S1 facet. So median branches we will target this one and this one. So here this lower one, this is a median branch which is actually coming from the root value of L5, and this median branch coming from the root value of L4. So this is of theoretical importance. This joint is L5S1, but it is supplied by root value one level above L4, L5. Okay, one median branch will catch here and one median branch will catch here. Okay. So after giving contrast, it spreads in the that area only. But one thing you have to understand, no area in the body is safe in that way that you cannot say that in some area intravascular, I mean, there is no vessel, so nothing to worry about. You cannot say. So this is only a facet joint median branch block. So you see the contrast spread. It is going inside a vessel. So this is very dangerous. This is going inside a vessel. So this is inside a joint. So here, so this is, I mean, nice spread otherwise inside a joint, but better spread is there. So this is, as I told you today, you can go, your needle can go through and through facet joint. So here also the facet, it has entered in the facet joint, but probably the tip had entered through and through. And that's why some drug or some contrast, if needle has not gone also, if there is a capsular tear, so some contrast has come in the epidural space. So here, if you give the, do the intervention here, then there is a every chance that this patient, after giving a diagnostic block, patient may have weakness of the leg because drug is coming here. So this is also, I mean, it will not give you any diagnostic value. This is inside the joint. Here you can see this is inside the joint, nice contrast spread inside the joint. Here also this is the nice contrast spread inside the joint. So this is a typical contrast spread inside a joint, but every time you do not see this. So this is also a typical contrast. So this one and this one is similar only. So these are typical contrast spread inside a joint, SI joint. So you can see in this patient some drug has come anteriorly. Okay, so this already I have shown. Another is last day transforaminal some facet SI. Okay, let's see if I can show you some. So this is transforaminal. So once needle is there, in AP view, you can see the contrast is growing, contrast is going and superiorly in like this in the epidural space. So you can understand this is the epidural space because this is medial side of the pedicle. This is the spinal canal area, medial side of the pedicle, it will spread. This is in the anterior epidural space. If it would have been a posterior epidural space, the spread, then you will see spread in this area, and not in this area. So this part is anterior epidural space and this side is posterior epidural space. So in lateral view, you must see that your drug is going in the anterior epidural space or not, because the compression from the disc protrusion is mostly in the anterior epidural space. So this is another drug spread nicely going. So see here the needle is placed in the right way, but drug is going, some drug is going intravascularly. Here this is a DSA machine, digital subtraction and angiography machine is showing there is a some amount of drug is going in the vessel, very small amount. So here if someone see very carefully, then he can see that this area is saying us that maybe some drug is going intravascularly. So doing these procedures, only one big risky thing is your drug should not go intravascular. Otherwise, the patient can have a very severe side effect, and that may you may land up in trouble. So so this is also a intravascular spread by after transforaminal. Okay, so I think okay, other as also there. So this is S1, through S1 needle has been put and this drug is going in the epidural space up in above direction, cranial direction. So this is okay, this is okay. So this is very nicely going. Here a caudal epidural, but after caudal epidural drug is going in the intravascular space. Here S1 transforaminal, needle is here, you see needle is much in opposite side, and drug is here spreading. That means it is intravascular spread, and clearly this pattern is also intravascular. So immediately you give drug here, it comes here. Okay. So here, this is not a intravascular spread, but this is not a acceptable spread. The patient, I mean, needle is in the foramen, but most of the drug is coming out. In the lateral view, you can see most of the drug is coming out. Otherwise, it is in the right place. Needle has gone in the epidural space, it is in the right place, but somehow the spread is not acceptable. Spread is going out, and a drug should go in the right place. So I mean, if there is some while giving contrast, it is not acceptable. You should not inject the drug, because you cannot waste the drug. So again, reinsert, reposition the needle and go in the right place. So this is the okay. So this is another view. You can see sometimes this is a caudal epidural, must be a post laminectomy pain syndrome after surgery. So you can see there might be many fibrous tissue and all. So after giving contrast, it is the spread is not bilaterally symmetrical. One side spread is there, another side spread is not there. So it should be nicely going. Cotton ball appearance. This cotton ball appearance means, I told you, needle can go and you can feel a loss of resistance over the sacral bone. And here, after giving, so someone have given some contrast. So this is in the muscle plane. So this is after the above the epidural space. So this cotton ball appearance is not correct. So now it has been repositioned again, and you can see now it is in the epidural space. This is also during epidural a vascular spread. So this is also needle is here, given being given drug here, and so much large vascular spread. So these are very risky thing. This is a someone is giving interlaminar epidural, but then it has punctured the dura, and it has become a subarachnoid injection. So here, how do you understand subarachnoid injection? Because the contrast doesn't go out through the foramen. It is limited by the medial margin of the pedicle. So this is in the spinal canal. Okay. So like that, it can happen that your needle is placed in the subdural space. Then only 1 ml of contrast will go at so much of height. So big level is in all levels it has gone only 1 ml of contrast. So this is the accidental placement. Nobody can put his needle in the subdural space in the spine intentionally, because this is a potential space, it is not a space. So this has been you have to take out the needle. So main thing is, I will say that, so there are multiple types of epidural filling. If these are not acceptable, so many epidural fillings are not acceptable and some are okay. So mainly I will say that you should see for typical contrast spread. If there is no vascular uptake, or you may see that okay, nothing is going to happen, but still typical contrast spread you must see. If it is not there, you should abandon the procedure. Okay, then good night for today.